Thank you, Dr. Coe and Dr. Goodman. I invite participants who have not already done so to send their questions through the WebEx Q&A feature or via Twitter using the hashtag LHI. We're also joined by Rear Admiral William Bailey, Jane Casper, and Daphene Altema-Johnson. These individuals can respond to your questions about this LHI topic and the presentations we've seen today. Rear Admiral Bailey is the Acting Director of the Division of Oral Health in the Center for Disease Control and Prevention. Jane Casper is the Vice Chair of the Maryland Oral Health Plan and a board member of the Maryland Dental Action Coalition. Daphene Altema-Johnson is an epidemiologist and evaluator in the Office of Oral Health at the Maryland Department of Health and Mental Hygiene. You'll be prompted to fill out a survey about your experience with this webinar during the Q&A session. We encourage you to complete the survey so that we can improve future webinars in our series. And let me thank you in advance for your feedback. We already have a number of questions that have been submitted. The first question actually goes to you, Dr. Goodman. Is there a master evaluation program for the implementation of the DAC recommendations? And are individuals' programs evaluated separately?
I'll answer the last question first, that yes, the individual programs are evaluated separately. In terms of the bigger picture, we really are evaluating the overall reforms basically through our Medicaid data that continues to improve every year. I think the bottom line in terms of the reforms was to, and similar to this Healthy People 2020 objective, to increase access to care. And so access will be evaluated in terms of the proportion of the population served, obviously, as well as the number of dental health practitioners that join the Medicaid program, as well as now improving also increasing the number of medical providers to provide new portals for access for the very, very young children who go to them through well child visits. So there is indeed an evaluation plan, and with Daphene Altema-Johnson, who's also our evaluation specialist, we're currently looking at how we're doing.
Thank you, Dr. Goodman. Jane, it looks like we have a couple of questions lined up for MDAC. The first question, how did the MDAC engage their partners and ensure continued commitment from their coalition members?
Well, actually, it's a very diverse group of oral health champions in Maryland, including Medicaid and our state legislature. And while the original Dental Action Committee's focus was on access to care for children, the mission of the MDAC is expanded to include access for adults.
Thanks, Jane. And one additional question, an execution question, how did the MDAC identify priorities for the Maryland Oral Health Implementation Plan?
Okay, there were 80 different stakeholder groups involved with the design of the Maryland Oral Health Plan. The MDAC split into 3 different groups, and we have co-leaders for each of those groups. The work groups are access to care, oral disease and injury prevention, and oral health literacy and education. And each of these groups was charged with coming up with the priorities and the activities to achieve the goals of the Maryland Oral Health Plan.
Thank you, Jane. Rear Admiral Bailey, it looks like the next question is for you. What is being done to address oral health among minority groups? Do you know of some successful community-wide interventions?
Yeah, there are a number of things done at the HHS level to address oral health among minority groups. One of those is, of course, to monitor the Healthy People objectives that are focused on disparities. Examples of things being done at CDC, for the first time ever, CDC oral health will be included in the CDC Health Disparities and Inequalities Report. We're also developing fact sheets for communities on water fluoridation that will be targeted to ethnic and minority population groups. As far as NIH, NIDCR is funding the Centers for Research to reduce disparities in oral health. They have numerous and varied types of studies underway on understanding and eliminating inequalities. The Center for Medicaid and Medicare has a new oral health initiative, And they have two performance objectives. One is to increase by 10 percentage points over the next 5 years the number of enrolled children aged 1 to 20 who receive a preventive dental service, and the second is for children aged 6 to 9 that are receiving sealants. Indian Health Service has a new Early Childhood Caries Collaborative that includes providers of many different types that are looking to decrease early childhood caries for children aged 0 to 5, with a goal of decreasing this by 25% over the next 5 years. And HRSA has a number of activities that are scholarships, loan programs, providing oral health services to people living with HIV, outreach grant programs for the Office of Rural Health Policy. There are so many things being done across HHS to address disparities. And as far as community interventions, there are also many, many examples of those. School-based sealant programs, especially those targeted at schools that have high rates of free and reduced lunch programs, children on free and reduced lunches. Of course, community water fluoridation is an outstanding preventive intervention that communities are working on. And many communities have also fluoride varnish programs that involve not only oral health professionals but other types of health professionals applying fluoride varnishes for children's teeth.
Thank you, Dr. Bailey. Dr. Coe, a question for you. Does HHS have resources to help states strengthen their infrastructure? Infrastructure is so critical in order to serve populations.
Well, we want to work closely with states and local leaders on this key public health issue, and in fact, we have an oral health cross-department initiative that was launched in 2010, and Admiral Bailey reviewed many of the highlights from many of the agencies. In particular, I want to stress that we have great leadership at CMS and at Medicaid, and there are some programs to focus in on particularly 8 state Medicaid programs that have really offered some new innovation here. So we're trying to take our current resources and integrate them and coordinate them even better. I should also mention that there's a very active new National Oral Health Alliance, and the advocates here have worked very strongly and closely with us. So we hope to take all these efforts up to a higher level in the very, very near future and maximize all the resources that we have at our disposal.
Thank you, Dr. Coe. Question that perhaps Dr. Coe or Rear Admiral Bailey can answer. How do we build better systems to promote oral health care?
Well, this is Bill Bailey. One of the things we need to do is to better integrate oral health into overall health care, and we're doing that by extending partnerships. Some of the partnerships that Dr. Goodman talked about, those types of things. But systems have to look beyond what is just those that involve just oral health proponents and people that are working in oral health, but they also have to involve the other health disciplines so that we can build systems that really focus on health and not just oral health, and to integrate oral health into overall health.
And this is Howard Coe. I would back that and support that, and also stress that Dr. Goodman's excellent presentation has many themes that we all can learn from as a nation, to involve other types of providers, to stress more communication with the public through an emphasis on health literacy, to bring in more kids through Medicaid particularly, because that's where the disparities are very focused. These are all very, very important themes, and so I want to echo what both Admiral Bailey and Dr. Goodman said.